Good morning, everyone. The topic that we are going to discuss today is Endo Perio lesion. Now, this is a common problem that you're going to encounter in your practice. Now, when you start your practice, a patient will come to you with a swelling in relation to a particular tooth. Now, you take a radiograph and you find that there is a radiolucency in relation to that tooth. So you think that, oh, this is an endodontic problem. You do a root canal treatment. You send the patient. Probably after a month or two, the patient comes back and say that he's got the same problem. Now, then you come to a dilemma. Now, what have you missed? Probably the lesion would have been a periodontal lesion, and now you have done an endodontic treatment. The problem has not resolved. Similarly, you have a, or this can happen the exact opposite, okay? You have an endodontic problem. For that, you do a flap surgery. But again, the patient comes back to you and with the same problem, that is same swelling. So this is something that you see commonly in your practice. So when a patient comes to you, you really have to understand whether this problem is of endodontic origin or whether this problem is of periodontal origin or whether it is of both. And then you have to formulate a treatment plan and treat that patient. So in this topic or in this chapter, basically we are going to discuss about the interaction between endodontic and periodontal problem and how we are going to address that problem when a patient comes to you clinically. Right. Now you all know about pulpal disease. Whenever there is injury to the pulp, whatever be the reason, it can be carious, it can be an iatrogenic reason, it can be heat, trauma, inflammation sets in, and it will result in pulpal disease. And you have different types of pulpal disease, like reversible, it can be irreversible. You can see a pulp, then the pulp becomes non-vital and become necrotic. So depending upon whatever the extent of pulpal damage, you address that condition. And usually, when that pulpal damage is confined within the pulp chamber or within the root canal system, it does not affect the periodontium. But you have different channels by which the pulp can communicate with the periodontium. Now, you all know that you have an apical foramen through which the pulp communicates. You have accessory canals, lateral canals. So all these are communications by which the periodontium and the pulp can communicate. So whenever there is a lesion in the pulp, this lesion can spread beyond the root canal system to the surrounding periodontal tissues and it can exert its damage. Okay? But usually, if the pulpal lesion, now usually it may extend beyond the confines of the root canal system and can result in a periapical abscess. And sometimes it becomes too chronic, it forms a cyst or a granuloma. And sometimes associated with the lateral lesion also, you may see some lateral radiolucency. You may, whatever happens is, you know, the periodontal ligament and the surrounding bone gets destroyed. And that is the result why you see all these radiolucency there. Now, what you do usually in such cases, you know that the lesion is of periodontal origin. You can do a root canal treatment and everything, the periodontium and the bone and everything, the lesion heals and comes back to original, or the lesion is healed. Now, what are the effects of periodontitis on the dental pulp? Now, if you have a pocket, will that pocket or that lesion have any effect on the pulp that is inside the root canal system? That is the basic idea. Now you, as we discussed earlier, you know, there will be lateral canals. So if your periodontal pocket is going to extend to the lateral canal, probably through the lateral canal, the inflammation can spread inside the pulp. Or if the pocket is very deep and it is going almost to the apex of the tooth, then through the apical foramen, the lesion can the inflammation can enter the pulp and can affect the pulp. So the inflammation, the surrounding, these are two, the pulp and the periodontium have different communications, and the extent of inflammation there detects the interaction between these two. Sometimes, they may, periodontitis may serve as a separate entity, pulpitis may serve as a separate entity, but then sometimes through these channels, they interact and they become a combined lesion. So that is basically what we are going to discuss in this chapter today. Now, how do you classify endoperio lesions? That is a basic thing. Now, a lot of classifications are available in the literature, but one classification that stands out is the Simon's classification, and that is what we are going to discuss today. Now, one is primary pulpal with secondary periodontal involvement. So, in primary pulpal with secondary periodontal involvement, you know that the lesion is primary, a pulpal origin, and through these different communications, the inflammation spreads from within the confines of the root canal system to the surrounding periodontium, right? Second is opposite to that, primary periodontal. So you have a periodontal pocket, and then through the different communication, the lesion extends into the pulp. So that is a primary periodontal with secondary pulp. Then you have true combined lesion, or where you have a periodontal pocket and simultaneously there is a pulpal lesion, and they are going to come and join together. That is a true combined lesion, or it may serve as separate entities also. Now, this is what is primary pulpal with secondary pulpal periodontal involvement. Now, look, you can see that, there may be generalized bone loss, a little bit generalized bone loss here, but you can see that, there is a radiolucency here in surrounding to that tooth. Now, you may find that in most of these cases, if you have a chronic lesion like that, here you can see that you may find that the furcation is involved. And you take a neighbor's probe and probe that area, you may find that the furcation is involved also. But is this furcation involvement caused as a result of a pocket that extends to the apex of the root or to the furcation area? Or has it occurred as a result of an accessory canal opening into the furcation area, or as a result of probably an apical lesion? You can see a large caries over here, almost involved in the pulp. So the tooth must have become non-vital. The infection must have come here apically, and it can spread here also. So so these are the different ways, in which you can see fine. So basically here, the lesion is of pulpal origin. So it has originated within the pulp, and probably through an apical foramen or probably through an accessory canal over here, this lesion from the pulp has entered into the periodontal ligament space, and it has resulted in destruction of periodontal ligament as well as alveolar bone here. So this is a primary lesion, pulpal lesion with secondary periodontal involvement. Okay. Now the second one, you have a deep periodontal pocket. You can see that you have a deep pocket like here, and it is almost extending to the apex of the tooth. So this lesion, when you have a deep lesion like this will be full of microorganisms. So these microorganisms will enter through the apical foramen into this pulp, and it can affect the pulp. So this is a primary periodontal. So there is no caries or nothing in relation to these two. So it is a primary periodontal lesion, and then through the apical foramen it has infected the pulp, and it becomes a secondary pulpal involvement. I hope you are clear with that now. So where the lesion originates, whether it is a pulpal or periodontal. So that based on that you can classify. Now you take this another scenario. You can see that there is a generalized horizontal bone loss over here. There is large restorations over here, caries over here. You can see an apical foramen or apical radiolucency over here. At the same time, you can find a furcation involvement. And this apical radiolucency is coming and meeting all this furcation involvement over here. So this becomes a combined lesion. So the periapical lesion, that is a pulpal lesion, is communicating with the furcation involvement here. So this is a true combined lesion. And you have independent lesion in relation to a single tooth. Probably you may have a periapical abscess over here. At the same time, you may have a deep pocket, probably about 7-8 millimeters. These two does not meet. So if the two does not meet, what happened? If the two does not meet, they are independent lesions. Then you will have to address both these problems in this patient. Okay. Now, how will you differentiate pulpal and periodontal lesions? Now, as I in the beginning, I said that probably the patient came with the spilling and you immediately went and did a root canal treatment. Now, what is the guideline in which, based on which you diagnose a pulpal and a periodontal lesion? Now, there are certain clinical features that are characteristic to a pulpal lesion, and there are certain features which are characteristic for a periodontal lesion. So, what are the features you see associated with periodontitis? Not all cases of periodontitis will have all these features, but most of the cases of periodontitis will have these features. One is pocket. You all know that is pocket. If you probe pocket of about more than 4 or 5 millimeter will be there. Patient complains of bleeding. If you press lateral to the pocket of the gingival sulcus, you may find that little bit of pus or fluid coming, and that is called as exudation. Patient they complain of bad breath. Sometimes over a period of time, the alveolar bone loss is progressed in such a way that the tooth will start drifting and spacing, and the tooth may be mobile. So these are some of the aspects of periodontal disease. But there are certain aspects of pulpal disease also. In pulpal disease, definitely there will be a filling, means there is a caries, a deep caries, or there is a history of trauma. Then the tooth may be sensitive. It will be sensitive to pain on percussion, and the pain will be mostly during the night, and the pain is more severe. So this is based on how you differentiate between pulpal and periodontal lesions. Okay, now basically this is a very important chart, based on how the patient is coming with an abscess. You have to differentiate whether it is a periodontal abscess or a pulpal abscess, and based on that only you have to treat the lesion. Otherwise, you do for a periodontal problem, you do a root canal treatment, and then it is not going to resolve, and then the patient comes back with a complaint, and then probably you said, oh, okay, now there's a periodontal problem, so we'll have to do a flap surgery also. So in the first case, you actually, if you had done a flap surgery, this problem would have gone also. So you really have to differentiate between a periodontal abscess and a pulpal abscess. In the periodontal abscess, the pain. So when you look at the pain levels between these two conditions, periodontal abscess, it is less painful, and especially the patient will complain of pain when he chews. Okay, but periapical abscess, it is very painful, constant, mostly night. Now, if it is a periodontal abscess, definitely there will be a periodontal pocket that is extending almost to the level of the abscess. You can be sure that there is a periodontal pocket. Okay, but if it is a periapical abscess, there won't be a pocket, but there will be a caries, or there will be a large filling, or the patient will have a history of trauma from time back. Tooth may be discolored also. Then location of abscess. In a periodontal abscess, it can occur anywhere along the lateral aspect of the root. To take a radiograph also, you may find a radiolucency anywhere along the lateral aspect of the root. But periapical abscess, the abscess is usually located more apically. And when you look at the vitality of pulp, that is in a periodontal abscess, the pulp is vital, while in a periapical abscess, the tooth is usually non-vital. So these are the basic differences. So looking upon the clinical features and these aspects, you can differentiate whether it is a pulpal or a periodontal origin. And then basically, based on that, you have to formulate a treatment plan. Okay, let's go to treatment. How do you manage endoperio lesions? The first is a primary endodontic lesion. What is a primary endodontic lesion? The lesion is of pulpal origin, and the lesion has spread from the pulp to the surrounding periodontal tissues. So what you have to do is you just have to do root canal treatment here. And suppose if you have a large periapical granuloma or anything, then probably you'll have to do an endodontic surgery. What periodontal treatment you have to do is just scaling. You do a scaling. Once you do a proper endodontic lesion, the lesion will resolve on its own, even if there is a large lesion extending into the periodontium. So that is a basic. So if you have a primary endodontic lesion, look, you can see that the large caries with radiolucency. Now, you don't do a flap surgery in this case. You do a root canal treatment here. Look, this is a textbook photograph, actually from Canal only. And they have done this during the stage of root canal. Now they have completed the root canal. And now you can see now probably about 6 to 9 months after that, complete this radiolucency. Look at this area over here. It's completely gone. So no periodontal treatment other than scaling was done here. So you just have to resolve the pulpal problem. All the bone loss, everything will come back. Bone will regenerate in that area. You don't have to do any flap surgery or any regenerative or any any more damage to the patient. Right. Now, if it is a primary periodontal with secondary pulpal involvement, so if you have, look, this is a similar condition. I mean, a condition in which you have a deep pocket over here, almost extending to the apex of the tooth, and through this apical foramen, this pulp is also become infected. So in this case, if you see this case, what you have to do is, in such case, initially probably, definitely you have to do a scaling. Then you have to see whether this tooth is vital or non-vital. If the tooth is vital, you can go ahead with your periodontal treatment. But if your tooth is non-vital, then you have to do an endodontic treatment first. Then you have to do a periodontal treatment. Why? What is the reason why in this case you have to do an endodontic treatment first, followed by periodontal treatment? Now, in this case, even though the lesion is periodontal, primary periodontal with secondary pulpal involvement, first thing, if you find that in this condition, if the tooth is non-vital, you have to first do root canal treatment. After that, you have to do a flap surgery. Now, suppose in this case you are doing a flap surgery first. What will happen? When you do a flap surgery, you open up all this area, you debride all this area, you have made this area very sterile, and then you close the flap. But you have a pulp that is infected with a lot of microorganisms. So what will happen is, through the apical foramen, all these microorganisms will come and recolonize this area, and it will have a lesion over there, and probably the lesion may not resolve also. So what you do is, in such condition, always, okay, you remove all the microorganisms from this area, you complete obturate that area, okay, this area is made sterile, it's sealed. Now you address this area. So in a primary periodontal with secondary pulpal involvement, always do a endodontic treatment first, followed by periodontal treatment. And then you can put the patient, after that, you can put the patient on a review and SPT. SPT is nothing but supportive periodontal therapy. So that is how you should plan your treatment. If it is a primary pulpal involvement with secondary periodontal involvement, all you have to do is endodontic treatment and scaling. But if it is a periodontal with secondary pulpal involvement, where the pulp is non-vital, then you do a root canal first, then you do a flap surgery, and then you put the patient on review and SPT. Now, suppose if you have it's a primary periodontal lesion, you can see that there's a periapical involvement also here. But this tooth was vital. This tooth was surprisingly, the tooth was vital. So what you do is you do only a flap surgery over here. And then look, after that, there's no endodontic treatment that was done on this. Over a period of time, the bone has formed, all these radiolucency has gone, it is healed well. So if primary periodontal, there is no pulpal involvement, by which you can make sure by means of vitality test. If a tooth is vital, all you have to do primary periodontal treatment only. Right. Now, you find a condition like you have both primary, periodontal lesion as well as pulpal lesion, and they are meeting. So then you should consider, when you treat this case, you should consider a case similar to primary periodontal with secondary pulpal involvement. So here, first you do a root canal treatment, and then you do a periodontal treatment. After that, put the patient on review and supportive periodontal therapy. Now, suppose it is an independent lesion, one, and they're not meeting each other. You have a root canal, you have a caries with a periapical lesion. You have a pocket that is about 5 or 6 millimeter deep. You can do at your convenience. You do a scaling first. Now, if you feel like doing a flap surgery first, do a flap surgery first, then do a root canal. And if the patient is having severe pain due to the, caries lesion, do a root canal treatment first. Later on, go for. There is, you can do it. When it is independent lesions, there is like the sequence is as you or based on the complaint of the patient. After that, you put the patient on review and SPT. So that is. So now we have come to the end of this chapter. Okay. So this is a condition. Endo Perio lesion is a condition that you commonly see in your dental practice, and you should know how to look for a periodontal problem. You should know how to look for a pulpal problem, and what are the signs and symptoms of pulpal and periodontal abscess. And based on that, you have to differentiate whether there's a pulpal origin problem or a periodontal origin problem, or you have both these conditions here. So if you have both these conditions there, then you will have to address based on the vitality of tooth. So basically, if you understand this, then in your clinical scenario, this becomes very easy and you won't make mistakes. Thank you. Thank you for listening.